So the title of my talk is Who Controls the Past, Controls the Future, Our Aging Blood Cells and Molecular Cancer Prevention. So the literary aficionados amongst you will recognize this title. This is from George Orwell's 1984, Who Controls the Past, Controls the Future, Who Controls the Present, Controls the Past. But don't worry, I'm not going to bring you on a dystopian Orwellian description of where hematology stands. On the contrary, I think this is a tremendously optimistic and positive time for hematology, and indeed for all of medicine, in particular for translational medicine. We're seeing this incredible, rapid translation from discoveries in the lab into the clinic, and it's such a privilege to be part of that and to be a physician scientist at this moment in medicine. So this being medical grand rounds, I thought I would start with a case. So hopefully most of you remember your internal medicine. I have a clinic, and so as a hematologist, when we get referrals to the clinic, the first thing we do is we look at the CBC. And so this was a patient who was referred to see me. He was a man in his early 60s. He had a normal white count, an elevated hemoglobin, elevated hematocrit, and elevated platelet count. So I was looking through his notes to sort of determine the acuity with which he should be seen in the clinic when I stumbled across this. And even a hematologist will recognize that this is not a normal EKG. I'm sure the interns and residents who are here will rapidly recognize that there's marked ST elevation here in the anterolateral leads, and so indicating an acute ST elevation MI. So this 6-year-old man who was really pretty healthy, had a very healthy lifestyle, has type 2 diabetes well controlled, went on a trip out of state, went to take some exercise, and unfortunately, in the course of exercising, suffered a cardiac arrest from an acute ST elevation MI, but thankfully was resuscitated and revascularized, had a stent put in his left anterior descending coronary artery. 48 hours later, he was discharged from the hospital and was doing great. And then they said, oh, well, you have these abnormal blood counts, so you should follow up and see your hematologist. And so that's how he came to see me. And so one of the really fantastic things about hematology is that it's very straightforward and it's very logical. And so with 3 blood tests, I'm able to make a diagnosis in this man. And so the first blood test I did was I ordered an erythropoietin level, and his erythropoietin level was markedly suppressed. It was below the lower limit of detection. I did iron studies. He had a mild iron deficiency. His iron saturation was 10%. His ferritin was 21. And then I did molecular genetic testing. So I ran a sequencing panel, a next generation sequencing panel that encompasses approximately 100 genes that have ever been described to be mutated in any kind of blood disease or blood cancer. And within these 100 genes, he just had 1 mutation. So he had a mutation in the JAK2 gene. He had the V617F mutation, which is an activating mutation in JAK2. And his variant allele fraction is 48%. So that's the ratio of the mutated JAK2 to wild-type JAK2 for the reads performed by the next generation sequencing. So with this information, I was able to make a diagnosis of polycythemia vera, which is a myeloproliferative neoplasm, which is a type of chronic blood cancer that arises due to the acquisition of mutations such as the JAK2 V617F mutation in the hematopoietic stem cell compartment. And so this is just some basic structure function of JAK2. As I said, it's a non-receptor tyrosine kinase. So what it does is it mediates signaling from extracellular components via cell surface receptors to downstream signaling pathways. So on its N-terminus, it has a firm domain. This interacts with the cytokine receptors. On the C-terminus, it has a kinase domain. This phosphorylates tyrosine residues on proteins. And then adjacent to the kinase domain, there's a pseudokinase domain. And this normally exerts a negative regulatory function on JAK2 kinase, but this V617F mutation, which is a single amino acid substitution that occurs as a result of a single point mutation, results in loss of this negative regulation. So you have constitutive activity of the kinase. And what that means is that this, you can have ligand-independent activation of signaling pathways. So this would be a sort of an example here. For example, this could be the EPO receptor. So if we look here, the sort of purple magenta color up here, these would represent 2 EPO receptors, and these are monomers, and this is the JAK2 molecule here. And so this is a situation where there's no ligand bound. Say, for example, EPO binds. Now the receptors dimerize, the two JAK2 molecules are brought together, they transphosphorylate one another, staph transcription factors are recruited, and the signaling pathway is activated. In the case of the mutant JAK2, and that's shown here, this green here represents the mutant pseudokinase domain, you can see that you have this activation of signaling in the absence of the ligand. And so that's how this individual ends up with a hematocrit of 60 and becomes iron deficient through EPO-independent red cell production, consuming their iron, making red cells, suppressing their EPO, but it really doesn't matter because they have this EPO-independent production of red blood cells. So when patients come to the clinic, I really like being a physician scientist because patients ask the best questions, and I'm always struck by how deficient we are in our ability to answer them well. So often and most commonly, patients ask, how did this happen? Why did I get this disease? And many times, of course, we're sort of lacking in knowledge. But in this particular case, I felt that we actually have good knowledge of how this mutation arose in this person. And part of that is based on some work that we did previously in collaborative studies that I'm going to share with you now that I was involved in when I was at the Dana-Farber and at the Brigham. So what we did is we performed so-called lineage tracing of the JAK2 mutant stem cells in individual patients. And to do this, we built on prior work that was really pioneered by Peter Campbell at the University of Cambridge in the UK, where he developed this ability to perform lineage tracing in normal tissue. And he started in normal human hematopoietic tissue. And then we just applied this methodology to JAK2 mutant hematopoiesis. So we studied 2 patients in detail. So what we did is we took their diagnostic bone marrows, and then we isolated individual stem or progenitor cells from the bone marrow, cultured this in vitro, expanded the colonies so we had enough genomic DNA to perform whole genome sequencing. And then we looked, since each colony is derived from a single cell, this is a clone, and this represents this individual stem or multipotent progenitor cell. And then what we can do is compare the sequence of these whole genome sequences from each of these clones to each other, and then look at their relationship, and we can create this lineage history. And we can segregate the clones that have the JAK2 mutation from those that don't. And so this is the first patient we studied. This is a 34-year-old man who presented with a JAK2 mutant MPN. And we had performed next generation sequencing, and we knew he had a JAK2 mutation as his sole mutation. He didn't have any coexisting mutations. And this is what we call his phylogenetic tree. So just to orient you here, what we're looking at is each individual line here represents a clone or colony that was sequenced. And we segregated those that have the JAK2 mutation from those that don't. Those that have the JAK2 mutation are in red. Those that are wild type for JAK2 are in blue. And then we're looking here on the y-axis at the total number of mutations present in that individual. And then what we can do is we can sort of look back and see for the JAK2 mutant cells, when was the common ancestor? And as you can see, the common ancestor is here. But for the JAK2 wild type clones, they go back much earlier in the life of the individual. And each of these branch points here, or coalescent structures, represents when the stem cell underwent a symmetrical division, and then it retained some mutations, but then acquired new mutations in that symmetrical cell division. So putting all this together, and I want to highlight that this work was really led by Sahandar Maz at Dana-Farber in collaboration with Isidro Siriana Cortez, and I was fortunate to collaborate with them on this work. And what we found then is that really this individual had this common ancestor we think they acquired the mutation around age 9. So acquisition of the mutation during childhood and then presentation in adulthood with this disease. We studied a second patient. This was a woman in her 60s. She has a very similar phylogenetic tree. The only difference is she has more total mutations because she's older and she's accrued more mutations during her life. But again, we found this same pattern, multi-decade interval between acquisition of the mutation and presentation with an overt blood cancer. So then the other part that Sahand was able to do is to look at the shape of these phylogenetic trees. And you can see where you have many branch points or coalescent structures here. This indicates that the cells are rapidly dividing, and because they're accruing new mutations. And so you can use that to sort of recreate or infer the growth rate of these stem cells in an individual person, and that's shown here. So this is the man who presented in his 30s who acquired the mutation at age 9. This is the total number of mutated stem cells, JAK2 mutant stem cells on the y-axis, and we're looking at time here on the x-axis. So here he acquired the mutation, and you can see that the stem cells expanded, and then around mid-adolescence, they really started to expand more. And really, they're expanding at a rapid rate relative to the other coexistent polyclonal hematopoiesis that is coexisting in his bone marrow. And then the second woman, she had a more kind of linear, consistent expansion of her stem cells. And so then there was an independent study, again from University of Cambridge, UK. They studied 12 patients and had very similar findings to ours with this multi-decade interval between acquisition of the mutation and presentation with the disease. And this was a particularly striking example that they reported in their paper of a man who presented at age 31 with a splenic vein thrombosis and was diagnosed with polycythemia vera. And when his lineage tracing was performed, it was determined that actually he acquired the JAK2 V617F mutation here very early in life, approximately 3 weeks post-conception. So in utero acquisition of the mutation. And then in a separate independent stem cell or parallel clone, he developed another mutation that drives the expansion of stem cells, a DNMP3A mutation, again around 3 weeks post-conception. So really phenomenal idea that we could acquire these mutations so early in life and then present in adulthood with overt disease. So the JAK2 mutation is called an MPN phenotypic driver mutation because it drives the development of an MPN phenotype. And as I highlighted, it does this because it interacts with these cell surface receptors and activates their signaling in a ligand-independent manner. And the key, this key receptor on the stem cell is the MPL receptor, the thrombopoietin receptor. And that, as I said, activates these growth and survival pathways that allow the cells to proliferate in the absence of the ligand. There are two other so-called MPN phenotypic driver mutations, and these are strongly mutually exclusive with the JAK2 mutation. The first is the calreticulin mutation, and the second is an MPL mutation. So in this case, MPL, the receptor itself is activated. Again, it can have ligand-independent activation of signaling. And in the case of the calreticulin mutation, it activates MPL signaling, and I'll explain to you how it does that now. So calreticulin is really super interesting. So I started my lab at the end of 2013, and a couple of months later, there were 2 back-to-back papers in the New England Journal of Medicine reporting calreticulin mutations as a cause of myeloproliferative neoplasms. And these mutations were discovered through whole exome sequencing. And it was really a very surprising finding because calreticulin is not a signaling gene. It's not a kinase. You can see here's its basic structure function. There's no kinase domain. It's actually an EOR chaperone protein. And so it has this signal peptide and the N-terminus that puts it in the EOR. It has these N and P domains that bind N-glycosylated proteins. And so it's a lectin. It binds these N-glycosylated proteins. It allows for normal protein folding in the calreticulin-calnexin cycle in the EOR. And then these receptors get exported to the cell surface. It has this C domain that has a lot of calcium binding sites that's important for calcium homeostasis. It has a KDEL sequence that retrieves it to the EOR. And there are recurrent mutations that occur. Again, these are somatic mutations. They're insertion and or deletion mutations in the last coding exon 9. And what they do is they cause a frame shift. So they generate a +1 base pair frame shift that results in the loss of this KDEL sequence on the C-terminus and the generation of a novel C-terminal peptide. So the C-terminus of the protein is entirely changed by these mutations. And so this was so interesting because it wasn't really clear, how would these mutations cause MPN? And so our lab worked on this, as did others. I just want to highlight here how altered the C-terminus is. So you'll see here's the wild type sequence with the KDEL, lots of negatively charged amino acids here. Here's the mutant with all these arginines and lysines very positively charged and the loss of the KDEL. And this, what's important to note is this is a common shared C-terminal peptide. So there are multiple mutations that can occur at the DNA level, but they all generate this +1 base pair frame shift and this common shared C-terminal peptide. And that's shown here where this group developed a monoclonal antibody against this mutant C-terminus, and they're performing immunohistochemistry here to diagnose CALR mutant MPN. And you can see here, these are 3 patients who have different types of calreticulin mutation, and they all have strong positive staining in their bone marrow, as opposed to other MPN cases where they don't have the calreticulin mutation and there's no positive staining. So what our group worked out is that actually, so normally calreticulin, as I said, it's a chaperone. It normally binds several receptors, including the thrombopoietin receptor MPL, binds and releases it. But in the case of this mutant calreticulin, it binds and has a sustained binding interaction and pathogenic binding interaction with the thrombopoietin receptor, and that's shown here. So these are transient transfections. We're expressing here wild type or mutant calreticulin, and it has a flag tag on it. We have an empty vector control. We're co-expressing the thrombopoietin receptor MPL. We're pulling down the flag and looking for co-immunoprecipitation. And as you can see, we're only able to co-immunoprecipitate the mutant form of calreticulin with MPL. And that's because the wild type binds transiently and then releases it, but this mutant binds and sustains the interaction, and that results in activation of the MPL JAK-STAT signaling pathway. So MPL itself gets phosphorylated, JAK2, and the STATs get phosphorylated. And so this is just a schematic summarizing that mechanism. So these 2 proteins interact in the endoplasmic reticulum. They sustain this binding interaction. The complex traffics to the cell surface, and then ligand-independent signaling pathway activation happens. So mutant calreticulin essentially functions like a rogue cytokine. And these patients present with marked elevated platelet counts and megakaryocytic hyperplasia in their bone marrow. And recently, the actual structure of this has been elucidated using cryo-electron microscopy, and has been demonstrated that these 2 proteins interact by forming this tetrameric complex here. So just to orient you here, there are 2 mutant calreticulin molecules here on the top, and you can see the different domains. What's important is that these mutants, C-termini, which are here, are actually exposed on the surface of the cell. And you can see these are interacting with 2 individual MPL monomers or TPA receptor monomers. And they're interacting at 2 sites. One is an glycan binding site. So their mutant CALR is binding through this glycosylated region in the extracellular domain of MPL. And then there's a second charge-based interaction between the positively charged mutant C-terminus and some negatively charged residues in the extracellular domain of mutant CALR. Of MPL, the thrombopoietin receptor. So obviously having this structure and having this evidence that the mutant is exposed on the cell surface is very exciting in terms of therapeutic targeting, and I'll tell you a little bit about that in a second. The other thing I want to point out is that like the JAK2 mutant MPNs, the calreticulin mutant MPNs have also been demonstrated to have this very long time interval between acquisition of the mutation and then presentation with the disease. And this is a really striking example that was reported several years ago from a group at the University of Oxford. So these were twins, and these were monozygotic twins, identical twins. 2 men, they presented in their 30s. One was 37, one was 38 when they presented to their hematologist, and both were diagnosed with calreticulin mutant MPN. In both cases, it was myelofibrosis, which is a subtype of MPN. And so the group set about understanding, how did this happen? Was these mutations germline? Were they somatic, et cetera? So what they did is they performed sequencing for the calreticulin mutation. And this is what you're looking at here. So these are DNA electropherograms. These are heterozygous mutations. So these 2 twins had a del52 mutation, so a 52 base pair deletion, which is the most common calreticulin mutation in MPN, calreticulin mutant MPN. And so you're seeing 2 peaks. The lower peak is the mutant peak. The taller peak is the wild type peak. And they sequenced myeloid cells, T cells. From one of the twins, they had skin fibroblasts, so they sequenced that. And then you have some controls here. And what you can see is that both of the twins had the mutation in their myeloid cells. Neither had it in their T cells. The twin B didn't have it in their skin fibroblasts, and the controls behaved as expected. So putting it all together, it looked like this is a somatically acquired mutation. Then they went on to perform lineage tracing type experiments similar to what I showed you for the JAK2 mutation, to look and see what mutations were common or shared between the twins and what were distinct. And so that's shown here. You have the cancer cell fraction in twin A, the cancer cell fraction in twin B. And the largest common shared clone was the CALOR mutant clone, and that's shown here. So both twins had this mutation, and then twin A had some mutations that twin B didn't have, and vice versa. So putting it all together, what the authors concluded was that the mutation was acquired in utero, and then there was twin-to-twin transmission, transfusion of the mutant stem cell from one to the other, and then the twins were born, and then you have some postnatal evolution with one twin picking up a TET2 mutation and the other twin picking up other mutations, and then they presented in their 30s with overt MPN. So this is really the natural history of CALOR MPN in a human being, or in two human beings here, with this very long time interval, as I said, from acquisition to disease presentation. And so this is part of this idea that you can have these mutations that arise in your stem cell that expand and then start to contribute to blood production. So they're disproportionately contributing to blood production because they're expanding at a faster rate than the non-mutated stem cells, is termed clonal hematopoiesis. And so this can be defined as overrepresentation of progeny derived from a genetically distinct stem cell that is measurable in peripheral blood. So we can sequence in peripheral blood for these mutations. And now there have been many genes that have been described to cause clonal hematopoiesis. And some of them can occur in early life, as I highlighted to you for the CALOR and JAK2 mutations. Others can occur later in life, but they're all strongly age-associated. So as we age, we acquire more of these mutations in our bone marrow. And they can also, the idea is that these mutations confer growth advantage or selective advantage, and that's why they expand and grow. And then there are probably external stressors that an individual is exposed to, for example, viral infections, or in some cases, therapies like chemotherapies that the patient might be receiving for a solid tumor, and that these influence which clones expand within the bone marrow. And then as we age, we lose clonality in our bone marrow, and our bone marrow becomes more oligoclonal. What is interesting is that even in this clonal hematopoiesis state, so this is where you have detectable clonal mutations in peripheral blood, but the individual does not have an overt blood cancer or a blood disease, and they typically would have normal blood counts. This in and of itself can be associated with the development of multiple other pathologies, both within the hematopoietic system, but also in other organs. And this is really just summarized here. So having clonal hematopoiesis is associated with an increased risk of development of an overt blood cancer. And these are some of the driver mutations that cause that. So these are shown here: DNMT3A, TET2, ASXL1. These account for about 2/3 of all clonal hematopoiesis. They're also associated with increased risk of solid tumors. They're associated with increased risk of vascular diseases. So our patient, his first presentation was a heart attack. But even in individuals who have just a mutation and haven't actually elevated their blood counts yet, this is also associated with increased risk of cardiovascular disease. And this is thought to be related to the fact that you have clonal monocytes, clonal macrophages, clonal neutrophils, platelets, red cells that have qualitative differences, are more pro-inflammatory and contribute to the development of atherosclerotic cardiovascular disease. They're also, the JAK2 mutation in particular, even in the clonal hematopoiesis state, is associated with increased risk of venous thrombosis. And then they're associated with increased risk of other diseases in other organs, like chronic liver disease, chronic kidney disease. And this is thought to be related to this inflammatory state of these circulating blood cells, these clonal blood cells. And then the one exception you'll see shown here in blue is that they've actually been demonstrated by Dr. Sid Jeswell, who's in pathology here at Stanford, to be associated with a reduced risk of Alzheimer's dementia. Then I'll just spend a few moments in the next part of the talk just to really talk about this idea of molecular cancer prevention. So could we target these clonal mutations? So let's start with the JAK2 V617F mutation. So currently in the clinic, to treat patients with MPN, we have several FDA-approved JAK2 inhibitors. And these are not mutant selective. They inhibit wild type and they inhibit mutant JAK2. So if the patient goes on the therapy and stays on it for many years, we don't eradicate their JAK2 mutated cells. So there's some benefits to being on the treatment, but we can't eradicate the disease. Therefore, we can't really cure the disease. So we are now starting to see the development of mutant selective inhibitors, and I want to highlight this abstract from the American Society of Hematology that was presented this last year, 2023, of a novel inhibitor that was designed specifically to target the pseudokinase domain of JAK2. And you'll remember that that's the region in which the mutation occurs. So again, we're back to structures here with cryo-EM. This is just this is JAK1, but it would be similar for JAK2. So this is the structure of it interacting with, in this case, the interferon gamma receptor. And so you can see here, this is the fermin SH2 domain. This is interacting with the receptor. This is the kinase domain down here shown in green. All of our currently approved inhibitors bind to the kinase domain. They're ATP competitive inhibitors. And this new drug is binding here in the pseudokinase domain. So there's a pseudokinase dimer interface. So this new drug binds actually to an ATP binding site in the pseudokinase domain. And this gives it selectivity for the pseudokinase domain over the kinase domain. And at least in preclinical studies, it has been reported to be much more selective for the pseudokinase domain than for the kinase domain. So these drugs are entering clinical trials. There's a phase 1 clinical trial that just opened in the last month or so. And in fact, I think this is a first in human clinical trial. This is an entirely new class of drugs. They're being tested in patients who have overt MPN. So they're being tested in patients with myelofibrosis. And I think the first patient actually in the world to receive this drug was treated at Stanford. And this is a study being led by Dr. Jason Gottlieb in our division. So currently they're being tested in myelofibrosis. So we'll have to see how they demonstrate, if they demonstrate clonal selectivity, how well tolerated they are, et cetera, et cetera. And then finally, I just want to talk a little bit about targeting mutant calreticulin. So I highlighted that mutant calreticulin is on the cell surface, and therefore targeting it with an antibody is a very attractive strategy. This is an abstract from 2022 from the American Society of Hematology, preclinical data with this idea that you could target it with an antibody in the cell surface and block mutant CALR, and in doing so, block the dimerization of MPL and block the signaling pathway. And this drug is also in phase 1, first in human clinical trials, also open at Stanford, being led by Dr. William Mullally in our group. So this is a kind of a blocking or neutralizing antibody. And then there are additional ideas about how we could target mutant CALR on the cell surface. There's a trial that's open where in addition to blocking mutant CALR, you also have a T cell component. So it's a bispecific antibody. So you bring the T cells to the mutant CALR expressing cells to try to kill the mutant CALR expressing cell. And then there have been some studies, mostly at the preclinical stage, on developing a CAR T therapy, so chimeric antigen receptor T cell therapy to target mutant calreticulin. And so these are really exciting because now we're starting to have drugs that actually target the driver mutations and might have clonal selectivity, which has been the deficiency of our treatments for many, many, many years. So with this idea, as I said, the antibody, the small molecule inhibitor of the JAK2 mutation, these are being tested in patients with established overt blood cancers. But if they are effective, if they're safe, if they are clone-specific or clonally selective effects, you could imagine that we could start to introduce these drugs earlier in the course of the disease and potentially even in this preclinical phase of disease, in the so-called clonal hematopoiesis phase of disease. And there's been a lot of work actually really trying to understand if we were to do that, which patients or which individuals with clonal hematopoiesis would be targeted. And this, I think, this study, which developed the clonal hematopoiesis risk score, I think will be very helpful in helping us navigate this space. So this study was performed using UK Biobank data and identified individuals who had clonal hematopoiesis and then looked at their outcomes, looked to see who went on to develop an overt blood cancer, and was able to stratify these individuals into high, intermediate, or low risk using a variety of parameters that are shown here. And essentially what the authors found is that the majority of individuals have clonal hematopoiesis actually fall in this low risk group. So about 89% fall in this low risk group, and their percent of likelihood of developing a blood cancer in 10 years is about 1% or less. And then about 1% of individuals fall in this high risk group, and they're 1% of the population, but they have a high risk of greater than 50%. So you can imagine if we had targeted therapies that are clone specific, this high risk group would be a good candidate group in which to try to treat these individuals. And the JAK2 mutation is amongst these so-called high risk mutations. So these are some of the ideas that we could use to target, or some of the mutations that could potentially be targeted. There are also ideas around targeting the TET2 mutation using hypomethylating agents and vitamin C, mostly in preclinical studies at this point. So the final point I want to make is that this notion that we are developing these clonal mutations as we age is not unique to the blood. In fact, we know that it's a feature of aging in all the tissues in our body, and we are actually mosaics, as this article demonstrated. So we are, we have clonal mutations in our heart, our lungs, our liver, our skin, and somatic mosaicism in blood is called clonal hematopoiesis, but this is actually a feature of aging. I also just want to mention two things. I did not have time today to talk about the germline, and there's actually really important information about risk of clonal hematopoiesis and germline genetic variation. And there are polymorphisms in the germline that are associated with the increased risk of developing clonal hematopoiesis. So for example, TERT, there are polymorphisms in TERT that result in long telomeres, and these actually allow you to have kind of longer replication competency, so your clonal cells can undergo more replication and survive longer. So this is associated with increased risk of clonal hematopoiesis. And then there's another polymorphism in this gene TCL1A that actually looks to be protective against the development of clonal hematopoiesis. And then the last point I want to make is that actually the majority of clonal expansions detectable in blood do not have one of these genetic drivers like JAK2. There's no identifiable genetic drivers. So this will be interesting if we ever get to the stage of doing molecular cancer prevention and start to, target these clones. What will happen, right? We'll impose a selective pressure against that clone, but will other clones emerge? And in an individual who's oligoclonal, what will be the consequences of that? So this will be all questions for the future that will be very interesting to study and understand. So that concludes kind of the science part of the talk. And then the last part I'm going to dedicate to talking about women in hematology in particular, because this is a very important for women in medicine. And so I'll just spend a few minutes talking about that, and then hopefully we'll have some time for questions about the work that I presented. So in preparing for this talk, I came across this quote: "Our future will become the past of other women." And I really like this. Unfortunately, I can't claim credit for it since I didn't come up with it, but it actually comes from a poem that was written by this Irish poet, Yvonne Boland, who was actually at Stanford for many years, was a professor of English here. And in 2018, she wrote this poem, which to commemorate the 100th anniversary of Irish women gaining the right to vote. So I'm just going to read a little bit from the poem and then tell you a little bit about some of the phenomenal women in hematology, both past and present, to conclude the talk. So the poem goes: "If we could only summon or see them, these women, foremothers of the nurture and dignity that will come to all of us from this day, we could say across the century to each one, 'Give me your hand, it has written our future. Our future will become the past of other women.'" So this is all of the women of hematology, past and future. And I like this idea of "Give me your hand, it has written our future." So I just want to highlight some of these women. So first of all, I want to thank Jason Gottlieb, who got me up to speed on the history of Stanford hematology and pointed out these phenomenal women who in 1972 achieved the rank of full professor at Stanford. And based on what I've read and understand of this era, there was not only a glass ceiling at that time. There was the whole building was glass, or probably reinforced steel at that point. So to achieve, the rank of professor at that time, I think was a phenomenal accomplishment. So Dr. Judith Poole, as many of you will know, she developed the ability to cryoprecipitate, so to extract cryoprecipitate from plasma, and cryoprecipitate is rich in factor VIII, and so that became a treatment of hemophilia. She was the founder and co-president of the Association of Women in Science and did a lot to advance the role of women in science. And then Dr. Rose Payne, she worked in this, in identifying antigens. So she identified that multiparous women had leukoagglutinins against paternal antigens, what were described to be HLA1 and A2. This obviously very important in allo transplant, and she performed some of the tissue typing for the first heart transplants performed here at Stanford. And then, I feel a tremendous honor to lead this division and follow in the steps of those who have gone before me, in particular, Dr. Linda Boxer sitting over there, who led our division from 2004 to 2017, who's currently our vice dean at the School of Medicine, a phenomenal physician scientist, advocate for physician scientists, and has made important contributions in the lymphoid malignancies. I took over the division from Dr. Bev Mitchell, who was the interim chief and led the Cancer Institute at Stanford from 2008 to 2018. Again, a physician scientist working in the heme malignancy space, in particular on AML. And then we have Dr. Ami Bhatt, again, a physician scientist, and Ami received the 2024 William Damashek Award, which is a really prestigious award from the American Society of Hematology for her pioneering work on the microbiome. And then you heard in our introduction, Dr. Tamara Dunn, who's the Associate Chair for Diversity, Equity, and Inclusion in the Department of Medicine, who led our Hem-Onc Fellowship here at Stanford for many years, and is probably, hopefully, a reason many of you became hematologists or oncologists and will continue to do so in the future. And then on the clinical side, we have Dr. Michaela Legge, who introduced me, who's our clinical chief of hematology, leading clinical trials in myeloma and ALL. Dr. Bita Fakhri, who's assistant professor leading clinical trials in CLL, Dr. Qian Zhang, who's a physician scientist focused on myeloid malignancies, and Dr. Elizabeth Price, assistant professor focused on anemia of aging. And then finally, last but by no means least, we have our classic heme women. Dr. Giselle Salmassi is the associate clinical chief of our division and expert in autoimmune anemia and sickle cell anemia, and together with Dr. Mei Chen is building our sickle cell program. And this is a very high priority for our division, given the tremendous advances in the development of gene therapy for sickle cell anemia. And Dr. Chen has a strong interest in hemoglobinopathies and has several trials in sickle cell anemia open currently. This time last year, you heard from Dr. Caroline Berube, sitting over there, who is a leader in hemophilia and leading clinical trials for gene therapy of hemophilia. And then last but not least, Dr. Bette Martin, who is our master clinician, educator, and expert on HLH. So these are the women who I just want to acknowledge and introduce you to in this important month of women in medicine, these women within our division. And then finally, this is our entire division. So of course, our division encompasses both men and women. I'm highlighting the women today because of the month that's in it. And I hope that if there's any trainees in the audience who are interested in hematology, that you'll consider joining any one of the amazing labs that our division has, or that you'll come talk to me if you're a student or a resident or a fellow about hematology. We'd really love to talk to you. I think it's a phenomenal specialty and such an exciting time to be in translational medicine, as I said. And then finally, I do want to acknowledge my own lab, which is currently in transition from Boston to Palo Alto. And my lab manager, Yip Yu, who's sitting over there, who's been getting us up and going. Acknowledge the past lab members who contributed to the calreticulin work, my longtime collaborator, Dr. Sahandar Maz, all the funding agencies who've supported our work. And then the very last shout out is that we're starting a new seminar in hematology called Breakthroughs in Hematology, and that will begin this time next week at noon. The first one will be in the BMI building. And we're very fortunate to have an amazing first speaker, Dr. Lachelle Weeks from Dana-Farber, who's a real expert on clonal hematopoiesis. And her talk will be clinical consequences of clonal hematopoiesis. And so I hope you can join to learn more about that then. So thank you so much. Happy to take any questions. Thank you for your attention.
Thank you, and that was a wonderful presentation. We're all kind of blown away. So any questions in the audience? Jim.
And great presentation. Thanks so much. Are there differences in clonal mutation burden between males and females that might account for the skewing of the clinical presentations of MPN more common in men than women? Have they uncovered a bit of that at all?
Yeah, so that is the case. So it's different for different mutations. So I think for the JAK2 mutation, it's likely more common in men than in women, but that's not the case for all mutations. So for example, I think it's the converse for the DNMT3A mutation. So yes, there are gender-specific differences, but it's mutation-specific also, or mutation-related. Yeah.
Hey, Ann, this is David McClose from BMT. First of all, again, welcome and thank you for coming to Stanford. It's really exciting to look at all the complexity of the clonal hematopoietic interactions. And of course, it's a puzzle we'll be working on a long time. Simple question. Difference between cancer versus inflammation, difference between lymphoid chip and myeloid chip. And maybe we'll learn more next week, but this is something we're falling into with the CAR T business. And it's dramatically different, isn't it? I mean, that's what we're learning.
Yeah, so you know, I've focused mostly on myeloid chip, which is driven by, you know, somatic mutations in the genes that I pointed out, DNMT3A, TET2, ASXL1, and then JAK2, as I pointed out. But yes, differences in lymphoid chip. We also see, you know, chromosomal mosaicism for chromosomal alterations there. So there's definitely distinct differences. And then some of the mutations can span both lymphoid and myeloid, as you know, for example, DNMT3A, TET2 mutations. So there's a lot of nuance in these individual mutations and in how they behave. And I think, you know, what's really interesting is that these mutations obviously exist in an organism, in a human being, right? So presumably they have some sort of selective positive advantage, you know, but then at a certain point that becomes maladaptive, right? And we get into overt cancer, and this has been termed adaptive oncogenesis, right? So it's really interesting that these mutations like JAK2 and CALR can arise very early in life. So they clearly are giving some, you know, selective advantage at that early time point, whereas some other mutations, for example, the RNA splicing mutations occur in later life. They come on in your 60s or 70s. We don't really see them. So I think it's all about the cell, the environment it lives in, so the microenvironment of the bone marrow, and then the, you know, constitutional makeup of that individual person has a huge impact, like I highlighted. And then we have all the environmental things. So for example, you know, the world we live in, viral infections that we're exposed to, external stressors that can impact us. So there's a lot going on. It's a very dynamic process that's happening. And for example, yes, if you put CAR T in the mix right now, you're taking out that clone, right, that malignant clone, but what's coming back, right? What is reconstituting hematopoiesis? And that might be different in somebody who's 70 versus in somebody who's 40. And then obviously the genetic makeup, the ancestry of that person, where they live, what they're exposed to, you know, what type of toxic chemotherapy. I know you don't give toxic chemotherapy in bone marrow transplant anymore, but, you know, all of these things, right? So it's a very dynamic process occurring in an individual person. So super fascinating, really, to understand and study more. And I think there's a lot of work to be done. I'm excited to do it. So all the trainees, you know, just find a lab and help us work this out. There's so much to do. Yeah.
Anyone in person? Okay, we have 2 online. Okay, so Dr. Levy asks, once you establish the genealogy of the JAK mutation among stem cell lines, how do you date the origin of the JAK mutation in the life history of the individual? Yeah. I had that same question.
Yeah. So it's essentially you, and I'm really not the right person to ask this. My collaborator, Sahan Darmaz, is really the right person to ask this. But the way I understand it is, you know, you have these, you sequence these individual stem cells and these individual clones, right, using whole genome sequencing, right? And you identify all the mutations that are present in each stem cell. And then you compare one stem cell to the next, right? And so the first thing is to segregate all the stem cells that have the JAK2 mutation from those that don't. And then you look at the additional mutations, and these are mostly private mutations within an individual. So you sort of work out at the time they have the JAK2 mutation, what additional co-mutations do they have? And then, you know, then you look at the stem cells that don't have the mutation, and then you can sort of work out at what point was that JAK2 mutation acquired. I hope that makes sense. But that's essentially what you do. You use these other mutations as sort of mutation. These would mostly be private mutations within a person to sort of track when was the JAK2 mutation acquired, and what additional mutations are present or absent. And then that defines the clade, right? The sort of clade that has the JAK2 mutation, the earliest common ancestor that has the JAK2 mutation. Then you have that individual so-called clade that is defined by the presence of that mutation. Yeah.
Okay, thank you. We have others in the room. Oh, yes, okay. Incoming chair.
You're going to sing a song every time I ask a question? I hope not. And first of all, thanks for an amazing talk. Also, welcome to Stanford. And thank you for showing a 12-lead ECG in your hematology talk.
What can I say?
Got to keep the cardiologists happy. I also would like to say you're clearly a worthy successor of all these other amazing women. So thank you for being here, and thank you for leading the division. My two questions. First of all, is it time to get rid of the I in CHIP? Because I think it's pretty clear what the potential is of this process. But so, and I notice you call it CH. What is the actual trigger of the inflammation, though? That's always puzzled me. So we have these clones, I understand that. But where does the inflammation come from? Because just the simple presence of a clone, is it those cells that are then signaling?
Yeah, so I think the way I understand it is really that there's qualitative differences in these cells. So, for example, in the context of the JAK2 mutation, there have been studies looking at neutrophils from these cells. So, if a JAK2 mutant neutrophil as compared to a normal neutrophil, right? And these neutrophils are more pro-inflammatory. They're more likely to form these neutrophil extracellular DNA traps, and we think that's actually part of the reason why individuals who have clonal hematopoiesis, so they have normal blood counts, it's not that they have hyperviscosity or high platelet counts, but they have these clones, that are circulating in their blood, and they have qualitative abnormalities in those blood cells. And then, for example, maybe you have some sort of trigger, that might incite a venous thrombosis, but then how you respond, right, is different because you have this more pro-inflammatory neutrophil. In the context of the heart, I think it's mostly been studied to be related to monocytes and macrophages, right? I mean, there's been a lot of work done on characterizing the inflammation and the inflammatory pathways in TET2 mutant monocytes and macrophages, and IL-1 pathways activated, other pro-inflammatory pathways. And that's actually led to this whole concept of targeting atherosclerotic disease with anti-cytokine therapy like the CANTOS trial, et cetera, et cetera. So I think it's cell-intrinsic qualitative abnormalities in these cells. And then probably there's some trigger, right? Plaque rupture in the heart, something that incites a predisposition to have a venous thrombosis. And then these cells don't respond in the same way that a cell that doesn't have the mutation. They have a more profound or more stronger inflammatory response. So I think that's at least one. There is some data to support that as a potential mechanism. Yeah.
Anything else in the room? I know we have a few online. Okay, a few more. Okay. So this is an excellent presentation. Are we screening older patients for clonal hematopoiesis and tracking changes over time?
Yeah, so screening has not started yet because that's a difficult one for the reason that I pointed out, right? The majority of people with clonal hematopoiesis, will not go on to develop an overt malignancy. I think, I will just highlight, I referenced a review article here from Dr. Conke and Majedi, and they have a really actually fantastic discussion of this whole point in that review article around sort of how do we actually deal with this on the clinical end. Like right now, I think people turn up to have clonal hematopoiesis because, for example, they have a solid tumor, they get cell-free DNA, and then suddenly it turns up a JAK2 mutation, and everybody's like, oh, what will we do with that, right? So they're sort of found in this way. I think they can be picked up as well in the context of somebody presents with a heart attack, early onset MI. We don't have risk factors. I think sometimes they're screened for or looked up for that. We actually wanted to start a study where we would screen for them in the context of a venous thrombosis, and then plan an intervention to target the JAK2 mutation in that context. But there's no established screening, guidelines currently, and it's in evolution. And I think what's really helped is these risk scores. So, go to Dr. Week's talk, she'll tell you more about it. But that's really helpful in distinguishing, who is low risk clonal hematopoiesis from who is high risk. If we had interventions, we would be focusing on the high risk group. But it's an area in evolution, currently no guidelines and no broad screening that's been applied.
Okay, and we have a question from our awesome colleague, Dr. Mullally, who has, as you saw in the talk, a trial open for some targeted therapy. And he asks, can we explain why we see CALR mutated PV when CALR only targets the MPL only?
Yeah. I think
that it activates MPL.
Yeah, that's really uncommon scenario that you would find that. So in general, these mutations are very strongly mutually exclusive. Sometimes they can coexist. When that happens, the mutation is in different cells, we believe, arising in a different stem cell. So all I could think is that maybe in that scenario, the JAK2 mutant clone is the dominant clone much bigger and is driving the phenotype, and the other clone for some reason is not contributing as much to the phenotype. But I think that's a really uncommon scenario. And there are these rare case reports like that, but that would be my only potential explanation, I think, or most likely potential explanation.
Right.
Okay. Thank you so much. I think that's
Thank you, Dr. Mullally. I'm going to hand it back over to Dr. Harmon.
Wonderful. Thank you so much, Dr. Mullally.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.